So we're going to move on quickly to Dr. Boneggio. Dr. Ramona Boneggio is a nephrologist at Boston Medical Center and a clinical associate professor of medicine and in nephrology at Boston University School of Medicine. Originally trained in South Africa and moved to Boston to do a fellowship in nephrology. And since then has concentrated on immune-mediated kidney disease and lupus nephritis. And he is currently the co-director of the Boston Medical Center Lupus Program and is an expert in the management of lupus nephritis. So really happy to have him here today to talk about immune kidney disease.
Hello, Gerald, and hello, everyone. Can you hear me okay? Good, very good. It falls to me to give you a quick introduction to the immune system, just to refresh some of your immunology, maybe from way back when. I always love it when my students say to me, Dr. Boneggio, you're making me go way back, and they mean way back like 1 year. You have to think about some of the immunology concepts. Let me see if I can get the slides to go forward. They're not seeming to respond to me. Can you take me to the next slide, please? There we go. Gerald has done most of the hard work here, so I'll skip this and next slide. I have nothing to disclose. I am on the VA's field advisory board, but do not have any enterprise conflicts. So today I'm going to introduce you to the immune system. I'm going to remind you that there are two components. There's the innate immune system and the adaptive immune system. And then we're going to talk about a few things that I hope will come up later on in the course as you talk about specific immune-mediated kidney diseases. And then we'll end with a couple of quick therapeutic questions or cases, just to show you that this basic immunology knowledge that we're gaining is actually becoming relevant to clinical practice. Next slide. Okay, so I'll just remind you that the immune system has two components. There's an innate immune system, and the innate immune system responds to patterns. So it contains what's called PRRs, pattern recognition receptors. And this responds to patterns that are often present on bacteria, on viruses, or produced by viruses. The job of the innate immune system is to protect one against infection by producing inflammation. Now, I'll remind you that inflammation is a bit different from immunity. Every time you cut yourself, you will have an inflammatory response in that area that prevents infection from entering your body, but it doesn't protect you the next time that you get a cut. So that's the big distinction between inflammation and immunity. You can see that the innate immune system contains cells, some of which you may recognize: neutrophils, macrophages, eosinophils, and dendritic cells. But then there are also circulating components that are molecular in nature, and some of these are becoming really important in our understanding of the pathogenesis of glomerular disease, as well as in the treatment of glomerular disease. And so I'll point out two things that I hope you will hear later on in the course. One is that the complement is part of this innate immune system, and the whole complement cascade would fall under that little picture. And then you will also hear about the important role of ApoL1, which is a lipoprotein responsible for improving immunity to trypanosomes and maybe other infections. And so, we know that this innate immune system is important in the pathobiology of glomerular disease. Next slide, please. Working in conjunction with the innate immune system is the adaptive immune system. And you can see that dendritic cells and other antigen-presenting cells sit at the interface between the innate immune system and the adaptive immune system. They take antigens, they pick them up and present them to the T cells, and T cells and B cells then produce antigen-specific responses, sometimes in the form of T cell receptors and cytokines, and sometimes in the form of antibodies, or usually both of those things. In contrast to what I told you about the innate immune system, this should produce long-lasting immunity. And this is how a lot of our vaccines work. We're hoping to stimulate an adaptive immunity response, and that will give you immunity against that particular antigen for a long period of time. Obviously, when we're talking about autoimmune disease, adaptive immune responses may be particularly pathogenic because they're going to last for many years. And in diseases like lupus or maybe IgA, this might be a problem that we have to address in terms of therapies. Next slide. So here's a couple of surprising things that we've learned in the last couple of years. I was always taught that the immune system was in the lymph nodes or maybe in the spleen. But it turns out that most of the immune system in the body, and actually most of the action in the immune system, is happening in the gut and in the mucosal associated lymphoid tissues. I never appreciated this at medical school, but our gut is filled with bacteria. And so there's a continual communication going on between our immune system and the bacteria that live within us. Next slide, please. So much of the immune system resides in these gut-associated or mucosal-associated lymphoid tissues. And you can see there that the immune system is sensing the antigens and the bacteria that are inside the mucosa or inside the gut. And it does that in two different ways. There are M cells or microploidal cells that allow antigens to move through the cell and be sensed by dendritic cells in the Peyer's patches. And then there are specialized dendritic cells that send these long snorkel-like appendages into the lumen to sense the bacteria. And so this is a critical to our defenses. We can't allow those bacteria that live inside us to escape and come into the blood. We know that that's a big driver of sepsis syndrome and acute renal failure. And this is how our bodies are preventing that on a day-to-day basis. Next slide, please. It turns out that gut-associated immune system is where most of the IgA is produced. And so this is the basis of the NefIgArd trials. And hopefully Jerry Appel will tell you more about this later on. But NefIgArd is a gut-limited steroid. And so the idea here is that you would be able to inhibit those dendritic cells that are sensing gut bacteria. That would dampen down IgA production and maybe improve the outcomes for people with IgA nephropathy. And if you can limit the steroids into the gut, maybe there would be fewer side effects. You can see from this phase 3 trial that was published a couple of years ago that they selected patients with IgA that were at high risk of progressing. And so these were people with relatively good renal function, but a lot of proteinuria. And that's a sign that, these are people that are at higher risk of progression than the average person with IgA. You can see on the right there that the primary outcomes were time-weighted GFR, and most of the patients completed the study, suggesting that the side effects were not too severe. Next slide. Here you can see that there was a significant reduction in proteinuria in these patients, and this is a good prognostic factor for patients with IgA. This reduction was seen in every, and the GFR benefit was seen in every subgroup that they analyzed. So it looked like this had real potential in these IgA patients who were at high risk for progression. The big problem with this study, and I'll say we don't very often use Nefigard because it's expensive, and unfortunately they did not have a steroid group as a comparator. And there are various reasons why that was not included, but it does make it harder for us to sort of convince, particularly in the VA where I work, to convince the pharmacy that this very expensive medicine should be used in contrast to sort of more traditional treatments for IgA. Nevertheless, I think it's an important point to say targeting this gut-associated, immune system may be a very effective way to mitigate against IgA nephropathy. Next slide. The second thing I want to tell you is that in the last couple of years, we've learned that B cells, especially naive B cells, undergoes sort of development. And in order to produce antibodies, they have to transition, they have to mature from a naive B cell into a plasma cell. Now, during this maturation process, they go through maybe some teenage years where they are very depressed. And what can often happen is that B cells can undergo activation-induced cell death. And in fact, that's the default pathway. So if you take a naive B cell and you stimulate that naive B cell, the default thing for that B cell to do is to die. In order for the B cell to overcome that developmental hurdle, it needs some kind of encouragement, some kind of growth signal. And there are two such signals, one driven by the BAFF receptor and the other one driven by the APRIL receptor. And there are several ligands that allow this to that engage these receptors. I'll show you those in a second. And this allows the B cell to grow from a naive B cell into a plasma cell. A little bit like we use erythropoietin to allow an erythroblast to develop into a reticulocyte. These are sort of growth factors required for B cell maturation. Next slide. Here you can see the sort of more details of the signaling. At the top there, those are receptors that are on the B cell. And I told you that they can be called BAFF and APRIL. And at the bottom are ligands that are usually on the antigen-presenting cell. And so you can see that the APRIL ligand binds sort of the APRIL receptor. I beg your pardon. Again, at the bottom are the receptors, at the top are the ligands. APRIL and BAFF are the ligands binding the APRIL receptor and the BAFF receptor. These signals provide that growth signal that allows the B cell to mature. Next slide, please. Now, what you can see here, these are data from sort of experimental cells that produce IgA. And it turns out if they're going to produce large amounts of IgA, and especially the deglycosylated IgA that we think is pathogenic in IgA nephropathy, they need three signals. They need a toll-like receptor signal, which is at the top there, TLR9. They need a cytokine signal, which in this case was IL-6. And then they need one of these growth factor signals. Here they're studying APRIL, which is thought to be the most important signal for IgA B cell production or B cell maturation. Next slide. You can see here that in experimental settings, if the APRIL signal is blocked, and you can see that on the right-hand side there, I've circled there blocking the APRIL signal, you see a decrease in the production of IgA in total, but in particular in the aberrantly glycosylated IgA, which is thought to be pathogenic. And then if you stimulate, you would never want to do this clinically, but in the lab, sometimes we sort of turn something off and we want to see that it makes things better. And then if you turn it on, so here they've stimulated APRIL, and you can see then the deglycosylated IgA production goes up. That's a good sort of experimental technique to show that this is really driving deglycosylated IgA production. Next slide. So based on these data, and there's an extensive literature on the role of APRIL in patients with IgA. There are now several strategies where this can be targeted. Here's one study of cipralelimumab in IgA nephropathy, and this was a phase 3 randomized control study, double-blinded and multi-centered, comparing this APRIL inhibitor versus a matching placebo. As I've put there, the patients were adults with biopsy-proven IgA nephropathy. They again were at relatively high risk of progression, and that's identified by people who've got significant amounts of proteinuria, even though they were on maximally tolerated ACE inhibitors or ARBs. And in many cases in this study, which is sort of in the modern era, so many of these patients were also receiving SGLT2 inhibitors. The primary endpoint was 24-hour urine protein at 9 months, and the secondary endpoint at this point was slope of GFR. And what you can see here, I'm just showing you the primary endpoint, but there was a fairly dramatic reduction in proteinuria that could be noted even as early as 8 weeks after the introduction of the treatment, but was not seen in the placebo patients. Next slide. Okay, talking about the adaptive immune response, I'll just remind you that T cells, and this applies to B cells as well. We used to think that these were only attacking, that they sort of would damage tissues or damage bacteria, damage infections. But we now realize that the immune system is more subtle than we thought. And here I've shown you, for example, that naive T cells under certain stimulations can become effector T cells, like the classic CD4 or CD8 T cells. And these effector T cells will enhance immune responses. But there are also hosts of T cells which suppress the immune response and are important in tolerance. And so I want you to look out for this as people talk about, let's say, transplantation, because it would be very desirable to have more tolerogenic T cells and B cells. And so we're going to be looking at strategies to do that. I'm not sure that any of these have sort of entered therapeutic realms yet, but certainly there are techniques to inhibit co-stimulation, which may favor the development of suppressive immune responses. Next slide. Okay, so let's do a few little questions just to show you that these things are relevant. These are not meant to be hard cases, so you should not be stressed by them. I'm going to start with a 62-year-old woman who presents with ANCA-associated rapidly progressive glomerular nephritis. And I want to know from you which is the least likely to contribute to the severity of her glomerular injury. Are neutrophils involved? Are B cells and plasma cells involved? What about complement C5a? What about the membrane attack components of complement? And are there antibodies to proteinase 3 or myeloperoxidase that might be driving this disease? Remember, I'm asking for what is the least likely to be contributing. Okay, maybe I'll go to the next slide. I see that there is some ambivalence in the audience. There are people who've selected each of these. Anyway, so I'm going to start off just by reminding you about the complement pathway. And I will remind you that there are multiple ways to activate the complement pathway. There is the classic pathway, which either can be activated by antibodies, and that's at the bottom there, a C1q complex, or it can be activated by mannan-binding lectin, which is a similar pathway shown sort of slightly above the immunoglobulin pathway. And these classic pathways involve C2 and C4 and eventually land up with the activation of C3. The alternative pathway is a pathway that is continually ticking over and is always at the ready to attack foreign material that enters your body. And this pathway has to be regulated. And you might hear in discussion of various diseases like C3 glomerulopathy, you're going to hear about what happens when the regulation of this alternative pathway goes bad. Finally, whether you activate the classic or the alternative pathway, you eventually land up on the right-hand side there with production of a membrane attack complex. And this is where I was always focused as a immunologist thinking of the role of complement. This membrane attack complex forms a pore, which then damages the cell membrane and allows foreign stuff to enter the cell and kill the cell. And that applies to both a human cell or a mammalian cell or a bacterial cell. One of the pathways I didn't think about very much is C3A and C5A are released during this process. And these are chemotactic factors that draw in other inflammatory cells. So they help to sort of accelerate the immune response. Next slide, please. Now, it turns out that in animal models of vasculitis, if you inhibit this chemotactic response, if you prevent neutrophils from coming into the area of the inflammation, then you can dramatically reduce how bad the inflammation is. So you see here's one experiment in a mouse model where they knocked out the C5a receptor and glomerular involvement was dramatically reduced, whether you look at crescent formation or necrosis. Next slide. You can see that also, like I explained to you previously, if you just take a B6 mouse, you get a certain number of glomerular crescents. If you knock out the C5a receptor, those crescents go virtually to zero. And that C5L2, that's a sort of ectopically expressed human C5a receptor, and there you can see that the crescents get worse. So on the left-hand side there, that suggests that C5a receptor is playing an important part in the pathogenesis of ANCA vasculitis, or at least in this animal model of ANCA vasculitis. In the right-hand graph, they have knocked out C6, and C6 is part of the membrane attack complex. And so you can see here, paradoxically, the membrane attack complex is not important, but the chemotactic component of complement is important. Next slide. Next slide, please. I used to then show this picture and say that we had started to use a Vacopan, which is a C5a inhibitor. But unfortunately, next slide, this paper was retracted in June of 2026. It seems that there were some irregularities and some of the data was changed after the unblinding of the study. This drug is still available, but at least in the VA, we have stopped using this until it becomes clear what the benefit of the drug is. This is unfortunate, but I don't want you to throw away the good science that came behind this study. I think there's very good evidence that the complement pathway is involved in ANCA-associated vasculitis, and it's mainly that chemotactic component. Okay, next slide. Finally, let's do a 62-year-old woman who, sorry. So I don't think the membrane attack complex is involved here. Next slide. Okay, here we have a 24-year-old woman who presents with nephrotic range proteinuria and an active urinary sediment. It's not a mystery. I think she has lupus and she's complaining of photosensitivity, hair loss, and arthritis. So which of the following are likely targets that may ameliorate her disease? Okay, I see again that there's some differing opinion in the audience. So let's go to the next slide. So it turns out, I think the anti-TNF, there are many anti-TNF medications that are now used for arthritis, but unfortunately, you'll notice if you have patients with lupus that these are not usually recommended for patients with lupus. In fact, they can cause lupus. If you look at the bottom there, that table 3, from this review by Williams and colleagues, you can see that almost all patients who are placed on an anti-TNF develop ANAs, anti-double-stranded DNAs, anti-histone antibodies. So, it seems that these anti-TNF medications actually cause the antibodies that are often associated with lupus. And it turns out that a fair number of the patients, up to 2/3 of patients, will develop skin features of lupus while they're taking these medications. So I don't think anti-TNF strategies are a good way to treat lupus. Next slide. I've already gone through this with you. Next slide. But it turns out that C2 and C4, those classical complement components, they're involved in clearing immune complexes out of the circulation. And so actually mutations in those are the number one sort of genetic cause of lupus. And so I would not recommend targeting early complement components. Later complement components may be different. Next slide. Here's a sort of pattern of how we think lupus develops. And you can see that we could target TNF1, interferon 1, I beg your pardon, as a way to modulate antigen presentation. We could target T cells with calcineurin inhibitors or B cells. Next slide. I think I'll just skip this and go to the next slide to show you the therapeutic impacts. So here's a treatment with anifrolumab that does seem to decrease the severity of lupus by targeting type 1 interferon. Unfortunately, when you do this, you get a lot of infections, and that's what I've shown you on the next slide, that there's high rates of COVID and other viral infections. Next slide. You can go to the next slide, actually. Next slide. Targeting B cells, though, is very effective. And so here you can see this is using belimumab, which is an anti-BAFF. And remember, BAFF is one of those factors required for maturation of B cells. And this prevents renal events or death and increases the number of people who go into complete remission. And we certainly use this a lot in lupus. It seems to be a very effective medication, but it's certainly not a cure. There's still many lupus patients who progress while receiving this. Next slide. And then finally, I'll mention that targeting B cells seems to be a very effective way. We've been doing this more now with obinutuzumab than rituximab because obinutuzumab seems to be more effective in lupus. And you can see here from this study from 2025, every subgroup that they looked at seemed to do better on B cell depletion with obinutuzumab. I must mention that we use this in patients who don't respond to MMF and prednisone. That's still the first line therapy. Next slide. Finally, for highly resistant patients, you may see some studies showing CAR T cells. This is a different way to deplete CD19 B cells, and it seems to be very effective. The problem is that it's also very toxic. And so we reserve this for extremely refractory lupus. Next slide. So, I cheated a little bit here. I think you could have chosen any one of those answers as correct. In our practice, we always start with mycophenolate and prednisone. And then for those patients who do not respond well, sometimes we add a calcineurin inhibitor. Oftentimes, we're targeting B cells using either an anti-BAF strategy or an anti-CD20 strategy. Next slide. So I'll stop there, and I think we'll be taking questions in a few minutes. Thank you, Gerard. Sorry about the technical troubles.